Hello and welcome to this special webinar. I would say some of us are now standing more or less on the beach looking out to the ocean and seeing a big wave coming, and some of us are in this wave at the moment. And for us it's a real big privilege to find out what is actually happening in those areas where the wave is really hitting hard in an attempt to maybe protect us. And with us I have, of course, a very renowned speaker, Helmut Brosch. He is from the Medical University of Vienna. He's a good colleague and friend of mine, and he is an absolute expert in the area of radiology, especially lung ultrasound and CT. And so, of course, since we all know that COVID-19 is a disease which strongly affects the lung, we're going to talk about that topic as well, and we're going to look at some images to see how patients actually present to have the disease. Can we maybe see Lara and Baldo? So here they are. Here is Lara and Baldo. Well, many thanks for coming on this webinar. I know that you have much on your head at the moment, and you're under, I would say, you probably can call it a war zone at the moment, but maybe can you just briefly introduce yourself and where you are from and in what situation you are now?
So we work in Tuscany, and now the situation is very bad because we have to, it's a race against the clock, because we have to change the hospital and create a COVID zone, isolate COVID zone. So we had to create a new bed because we have a lot of people with COVID-19. This is the situation.
And my name is Baldassare Ferro. I work in the intensive care unit of Livorno with Lara Vignuti, that is my colleague and friend. And we work most of the time in the intensive care unit with a particular interest in the ultrasound and echocardiography.
Well, thank you very much. And maybe can I also introduce you to Jonathan? Jonathan, maybe can you also describe your working environment, if you can call it that, and also maybe your position?
Hi, good afternoon to everybody, and thank you for inviting me to speak during this webinar. Actually, I'm a resident in anesthesia and intensive care at the University of Ancona, but last month I was moved to a more peripheral hospital. That's a middle-sized hospital, and then it ended up to be the red zone, one of the red zone of central Italy. And actually we have locked down our hospital, so now we don't have any elective surgery. We migrate most of the normal ward to a more smaller hospital, and we are a COVID hospital, so people cannot get access to the emergency department, and even they keep coming by car alone. And actually, we usually have 8 ICU beds, and now we arrived today to 36 ICU beds. So our main challenge is do what we are good to do, because you can imagine that we don't have nurses that work usually in ICU. We came back to paper. We have to compute manually input and output of fluids. So for us, really struggling to do what we normally do. And especially we were not prepared to such a break. So that's the situation. Actually, we feel to be like in war with no bombs. I mean, we have patient coming, arrive with saturation of 55, and we have to do something.
I mean, this truly really sounds like a war zone, something that nobody would ever have expected to be possible in this extremity. I think, how do you cope with these situations now from a very personal aspect? I know, Jonathan, you have a very small kid at home. I know that you are, of course, very active in the research space. How do you actually cope with this on a day-to-day basis?
The little one has 10 days, and actually we were living close by to Granny, so we have to move out a couple of weeks ago. We have now rapidly rebuilt a small apartment where we are living. And then I have the ICU shift, and then, as you know, we are working on we have already created a platform to collect data, because the major frustration is not to understand where the patient goes. We have patient normally intubated for 10 days, and we still not see if the patient is going to improve or not. So for me, it's really a demand to work 24 hours per day.
I mean, I also see this as one of the big problems, that there is not enough information at this point. I mean, nobody really has the time to really collect data at this point. We're just fighting to survive. And this data is so important because we need to know how to treat these patients. And part of the reason we're doing this webinar is actually to spread this information so that we get your experience and can pass it on to those who will need this information as well. But let me pass the question to Lara and Baldo. What about the situation in your hospital? From a private perspective, how do you cope with this?
The situation is similar to that explained by our colleague. This is a logistic situation that is awful because you have to convert the hospitals and to introduce new nurses to a new type of work and doctors that normally don't do this type of work, doing another work. And so one problem is the professional aspect, and the other is the fear, the continuous fear to be infected, because we are seeing many young patients that with a very bad prognosis determined by an unexplained multi-organ failure that die, and they don't have any previous pathology that can explain this deterioration. So there is the fear, and there is the sadness to not understand why a lot of patients are dying.
Yeah, that sounds really dramatic. I mean, obviously, it's also the health of the healthcare professionals, which is very, very important. I mean, especially since we're also the caregivers, and if we cannot give care, then we cannot help the patients. And is it correct that you're now using healthcare professionals from other areas, from disciplines that are not usually in the setting of intensive care unit to assist you there?
Yeah, like in our department, in our hospital, we are trying to create some multi-professional team, yeah, that can afford the problems. In particular, in the infective disease department, some pneumologists are going to do non-invasive ventilation, and we as anesthesiologists and critical care doctors are going there to help to reduce the possibility of intubation, to avoid the complete occupation of our intensive care unit. And we are going to open another intensive care unit with 8 beds that is very far from our commonly used intensive care unit, with other nurses that commonly don't do this work. So it's a very difficult.
Let me ask a question to Helmut, because we're in a different situation now. How are we preparing now for such a situation, or what is being done now, especially in the radiology department, which will definitely be confronted with the situation of COVID?
Yeah. What we did in the last few days, we tried to prepare ourselves for the situation. We canceled all elective imaging procedures, so only urgent cases are now being scanned, and we reserved one of our CT scanners exclusively for patients who present with symptoms which could be COVID, or with patients who have COVID. So we try to separate patients who are infectious from patients who are not. And also all the surgical procedures are now being limited to the ones who need to be done in order to make space for at the intensive care units. We're still waiting.
One question that is on my mind, and I think we'll have time to discuss that, is first of all the presentation of the patients, but also we come into situations that I can imagine where you will have to decide where will you put your efforts and where do you think you can get the best outcome. What is your take on this, and how do you manage this in your practice?
You know, when the war arrives, you should be prepared, first of all. But we have not been prepared to fight this war. and our hospital try to put the best effort to remodulate the occupation of the intensive care unit or the bed in the hospital. But many of patients arrive at the emergency department and they need an intensive care unit because they have very important symptoms in which only monitoring or low intensive care is not recommended, and they deteriorate very, very fast, and so it's we cannot understand the evolution of the symptoms and the prognosis of the patient when they arrive at the emergency department, as we do with the other pathology like pulmonary edema or heart failure or stroke. So we put there in a department, try to give the best care that we can, and we bet on them at the moment.
If we look at the death rates, and if we look at the number of people who have actually died around the globe, we now see that obviously China is very far up there, and you've got Italy and Iran, Spain, US. But what is really intriguing is if we go down now to look at how many patients die with respect to the amount of patients there are, we see that there are very, very big differences in, I would say, mortality. You might not really call it mortality because it's much too early to, to decide whether or not the patient will die or not. But it does show a trend. It shows a trend that some areas have a much higher mortality than others. And I was just wondering if you have an explanation. Maybe Jonathan, you can comment on that and why you think that in Italy we have such a high mortality opposed to other parts of the world.
So this is a really interesting question. Actually, there could be different explanation. We started now to test only symptomatic patients, and actually, so you have to have moderate symptoms to go to the hospital and be tested. That can explain why we have higher mortality compared to testing. And then we have one of the whole population in Europe, and we have a social system where usually granny take care of kids. And we know that children are usually asymptomatic and they can spread the disease. Indeed, we are seeing, yes, younger patients, mainly obese younger patients, but we are seeing a lot of patients that are above 65.
I mean, we need testing. I think this will be very, very important because we need to find out what the number of infected patients actually is to prevent the disease from spreading. And I can only reiterate what I've also heard from other colleagues from Italy. That one of the major problems is that, of course, the schools closed and the kindergartens closed, and then the grandparents were taking care of the children, and that's how probably one mode of infection was also spreading to the elderly population. I do also want to answer some of the questions which are coming in because we see that there's tons of questions. I see I have over 7,500 contributors to the webinar. So the interest in the community is so enormous, and we want to give everybody the chance to, of course, learn what they need to know. And one of the major questions we keep on getting is, how do we protect ourselves as doctors? And what is the situation in the Italian environment, where I would assume you might have problems that maybe protection device is not even available? What do you do in such situations?
So we have a protection device, individual protection device, with the mask, eyeglasses, and we cover our body too. And when you put all this kind of wearing on you, it's very difficult to work, but you have to protect it. But you work with the fear that you can be infected. And, in a market, you have an offer and a demand. The demand of these DPI, the individual protection devices, increased a lot in Italy, but the offer is quite low. So we are living this imbalance between demand and offer, and we fight to preserve our DPI to work safety.
Yeah. I see this as a big concern. I've heard that some medical professionals we know from China, we know from other countries, have already, of course, died due to the disease, and which is very tragic. Many of them are very young. So yes, we are at risk, and again, I think it's very important. I mean, I can only tell I've been in contact with many, many doctors, and there's a very big sympathy for you in Italy, for the situation there. Even across the industry, I must say, I've been talking to some people that have asked me, how can you provide care and help? So of course, if we can somehow maybe give you the care you need, that would definitely be great. And I can only also say that we got a very kind support for this webinar also from two companies, from Novartis and from Siemens. I want to thank them very, very much for being on board here, because it's very important what they're doing as well. But again, I just must state that the sympathy is there, and we have to learn from your experience. How do we do it in our hospital, Helmut? What how do you protect yourself, or how is it planned to protect?
A tough question. We are currently lacking behind, fortunately behind Italy. So we are, as mentioned, we have an area of our department which is defined as the potential infectious area, with the CT scanner which is reserved for these patients, and there we have the full protective clothing. And in other areas, it is still the fear that we might run out of masks and so forth. So as long as this is still contained, we have to save our material as well.
Yeah, that's a big issue. There's a shortage. There's now initiatives to get more of these protective gears to us, and there's also, of course, some initiatives to produce them in Austria ourselves. So this is a big, big concern for our country and our doctors. But I guess we really have to share the resources we have, and I just want to mention that too, because I just recently came across a video that was posted by a doctor showing that actually some people are stealing materials in hospitals, and at the moment what is happening is that hygienic materials such as, for example, disinfectants are treated almost like opiates and not given out anymore, because we have to take care of the resources.
There's several questions already.
Yeah. There are some questions. Do you want to take one of the questions?
One question was in regard to these ground glass opacities. What do they reflect on a pathological level? We don't know, honestly, but we know it from a few autopsies performed from China. And what we see there is diffuse alveolar damage with the formation of these hyaline membranes. So it's a combination of a interstitial edema and also alveolar edema. That's the place where the infection is going on. So it's not the place of superinfection. That's where the COVID infection or the COVID is going on.
Yeah. I see that there's a lot of fear. Jeannie has asked the question, what can we expect in New York City? I don't know if you're aware, but there was an explosion of cases now in New York City. People are working and looking in a very close vicinity. So yes, definitely this is a concern there as well. I guess the answer to that is not easy. It's just, I guess, what we do not want to have is that it explodes and that we cannot control anymore. And that's exactly why we're doing this webinar, to protect us from this. But we have to be aware that this is certainly something that can hit all of us, and that's why it's so important to prevent it from happening in the first place. Good. Do you want to maybe just mention something else in respect to the epidemic and testing?
There are a number of questions about the tests, and I think the test policy depends on the availability of tests. So here in Austria, they are now ramping up with the tests, but still they have to select patients who get tested, because we still are not there where we want to be. Tests will become available. What we hear is from each and every country, but testing is really important.
Yeah, it's a big concern here as well. Doctors are afraid here. We might have more infections among our doctors than we have some of cases in our hospital already, and we don't know if there's maybe more. Some have actually mentioned that maybe it would be good to just have the antibody test, because if you know who has antibodies, then that would have definitely be good. Yeah. I mean, all of you who are out there, I think we have to be aware that we as doctors are now in a completely different situation. It's not, helping a patient. And, we always said that the true hero is always the patient, because he is risking his life. But in this situation, it's a bit different. We are also risking our life. And so I think in a way, I can only say that, yes, there's a lot of sympathy. And, we can only hope for all of us and for the rest of the world that we will not come into a similar situation. And definitely will give all the support to those people who will need it. Maybe in that respect, I can only mention that, I think one of the big difficulties that we see here is that this information flow needs to go, and that's exactly why all of these tips are so important. What we can do on our side is obviously also to provide you with information of how you, for example, can provide or can perform lung ultrasound, and we're actually planning a lecture. We're filming that on Sunday, and we're going to distribute that obviously for free to everyone to look at, so that they maybe have some tool in their hands that they can use, especially in these critical situations. I know, Helmut, you are one of the leading figures in the area of lung ultrasound. Do you want to maybe just discuss how this field is evolving and what some of the pitfalls are? Why is it not really being used as much as it should be?
I think one of the domains where lung ultrasound is primarily used is the intensive care, to monitor patients, to diagnose complications. And Italy is actually in the forefront there. Many of the most prominent researchers in that field are coming from Italy, some from France and Germany as well, but then there are really experts coming from Italy. And the thing is, what you need to do in lung ultrasound is you have to scan. You have to get your experience. It is like with all ultrasound procedures, you can get the basics from lectures and from books, but at the end of the day, you have to do that on a daily basis, scan your patients, and get used to your machine, because the ultrasound machines vary in their ability to show these artifacts, and you have to get used to how these pathologies look on your machine. But in essence, it's a method which is not that difficult to learn, and you have to start right now.
Yeah, it's quite easy. You know, we always said lung ultrasound is not a technique that we should be using, because lung is the barrier to ultrasound, while air is the barrier to ultrasound, so it's not a technique that should be used. But we now learn more and more. Aside from lung, there's many other applications as well. But just because I'm seeing so many questions appear here on the screen, we now have somewhere in the excess of 450 questions with all the questions which just came in before. I'm afraid we will not be able to answer them, but we were expecting that. And so actually what we built in the background is a little bit of a knowledge base. This is a webpage that we created now. We call it Doc19. I guess you all know why we chose the name. And here will be a kind of a platform, a resource where everybody can get the answer to what he is asking. We, of course, have not uploaded all of the questions yet, and we're waiting for some of your questions to come in so we can answer them. We'll put them there so everybody can read them, and they're always available in a very simple format, in the format of an FAQ format. So that's where we're going to answer some of the questions, and many of the questions from here, especially I see on hygiene and how we should protect ourselves, but we'll answer questions on what are you supposed to do in special clinical situations, how can you treat patients. Lung will be a very important topic there. So visit us there, sign up, and please feel free to also put your questions on there. And we'll see if we can recruit more people that will work on these questions to provide a true database that we can all share. Okay, so I think we will go back to maybe Lara and Baldo, and maybe you show us the case that you have, because I know you've collected some very, very interesting cases or figures. And if you don't mind, I will play the slides from our side so that you don't need to switch them, and I can simply just comment on them. And I think you can see them on your screen, can't you?
So the X-ray is not quite bad, but the situation underneath is very, very bad, like you see in CT scan. So scan is the best exam. CT scan is the best exam that you can take if you're able to have.
Mm-hmm.
So
another thing is that the X-ray is similar to the clinical symptoms, because when the patient arrived at the emergency department, he has most of the time dyspnea. But when you put some oxygen, he starts to breathe normally, and you think that all is going well. But when you perform a CT scan, many times you see a very bad situation in most part of the lung. And talking about what we see in the lung, when you do this CT scan, is like when the CT scan is similar to an autoimmune disease. I have seen a patient 1 years ago with a lung vasculitis that presented with a CT scan very similar to that we have seen in COVID-19. So the autoinflammatory disease in this pathology can be a key in understanding the evolution of this pathology. Maybe the damage of the virus on the lung is not the most important thing that we have to take care, because if you see, you have a spreading of the pathology from the peripheral part of the lung to the central part of the lung that is typical of immune involvement of the inflammatory involvement of the lung. And tolicizumab.
Maybe I can just ask Helmut, you saw the CT, you're an expert. Is this a case where you would say it's a very severe form, or how would you interpret this?
That it's at least quite extensive form of this disease. The case I showed you before were these limited cases, and I showed just this limited case because I knew that you had this more extensive cases. And if you look at this picture, as mentioned also already by Baldo, this is not specific. You find this CT picture in a number of diseases, in edema, in infections, in pulmonary hemorrhage. And also when it comes to infections, you would primarily consider viral infections, but it's not specific for this disease. So this always has to be seen in the context, in the times we are living. The most likely diagnosis is COVID.
The question for me is, maybe you can also comment on that. It's probably not the matter of making the diagnosis, because the diagnosis has pretty much been established through the tests and the clinics. It's probably more looking at the prognosis and how we can manage the patients.
Unfortunately, there's no system on how to predict prognosis in these patients. As far as I know, there are some proposals to do that, but as of now, we look at the extent of the disease, and the more the worse. That's easy to say, but we don't know exactly to which patterns indicate a worse prognosis. Problem is, lung has only a limited number of reaction patterns, and that's what we see. We see here an ongoing reaction towards the stimulus, this injury.
Let me have Jonathan again, because I know that he's very strongly involved in trying to figure out what the risk populations are. Jonathan, what approach are you taking?
What seems to be the worst prognostic factor is age. Then it's really scary, because we have patients older than 70 years old with almost no comorbidity that they don't survive. And this is really it's really difficult to understand, because we were measuring a lot of laboratory values. We saw that creatine phosphokinase and LDH are more increased in severe patients, in non-survival. We also know that that D-dimers elevated are related with bad prognosis, but these are all a specific factor. So the reason, again, why we create this international data set is exactly to try to register more information and try to find out the clusters of patients, because we are working with artificial intelligence, and we think that the new methods of artificial intelligence can help to find cluster of patients, because of course obesity is prevalent and hypertension is prevalent in the patients, but we don't have many women, for example, obese. We have few women, we have a lot of men, we have young male that are overweight, but not in one individual factor is associated to prognosis except age. So patients above 70 years old that are admitted, that they require admission in ICU, they have really the highest mortality, as long as we have seen. And talking with other colleagues, we always end up to this conclusion. So, but making a triage also on age is really crude way. We need something. At the moment, we are giving chance to everybody, but we have reached the maximum beds, ICU beds we can afford. And still we have patient intubated after 2 weeks, and we don't see the direction. We have some idea. I totally agree with Prosh about the fact that the edema that you can see in the CT is one of the major pathogenic factor, because it seems more to a left heart failure than a normal RDS. These patients are full of water, and that's why they improve with PEEP, with high PEEP, and also they keep a compliance. So the lung can still breathe normally, really high PEEP. That's not at all what we see in usually RDS. So, and there are other characteristics, like all patients get hypoalbuminemia. They get marker of edema. If you use PICO to measure the extra lung water, then they have almost double the level of normal value. So I think edema is really a trigger, or like in the pathogenic way.
Yeah. As a matter of fact, one of the questions we got from our users was, is it different from from acute respiratory distress syndrome or not? I guess the question was answered. Would you agree with that, Baldo and Lara?
I think that when you have not heart failure causing edema in the lung, the problem is inflammation. So the cause inflammation in this situation is or the cytolytic effect of the virus, or the inflammation or the lung determined by the infection. So again, I think that to take care about this edema, the ventilation maybe is not the key, but we have to understand the mechanism of this edema and to fight it before that the inflammation spread up. Maybe we are using anti-inflammatory drug at important like tocilizumab or immunoglobulin or plasma, as written by Chinese colleagues, and maybe we are doing these therapies very late when the inflammation spread up. So maybe the indications in this situation are different. We have to discuss maybe with the rheumatologist. Maybe I have an interference because my brother is a rheumatologist, but he talked me about this. For me, is an autoinflammatory disease, a very bad autoinflammatory disease that must be cured before that the inflammation spread.
Yeah, many open questions. I think, of course, what Jonathan said, we need more data on this, and we will present at the end of the webinar, we'll present, of course, the platform that he started, which is a fantastic initiative where intensive care units from all around the world can participate to enter their data so that we can get more meaning. And I like the aspect of using artificial intelligence there as well. But maybe we can go on with your case, because I actually interrupted you in the midst of it and we're not through your presentation. So we saw the CT, and I'll just switch to the next slide. I think
in a few days, the X-ray going worse. So these patients are going bad very, very fast.
Yes, as we've seen, when you start to take care about this patient, you see a quite normal X-ray, and the deterioration is very fast. There is a moment in which the patient compensates very well, and in a few hours, the patients need intubation. And what we have seen in a lot of X-rays that there is a deterioration of opacities in the X-rays, but there is too an enlargement of mediastinum that can be considered in this pathology. I will present some echocardiographic images later, so you can discuss with us, because you are an expert about this. So
yeah, we're glad to take a look at the echoes.
Yeah, so you have a deterioration X-ray very, very fast. If you go with the next slide, you will see instead that these patients recovery their lung very, very, very slow, and they need intubation for a long period. So it's not an edema, a simple edema, because it doesn't disappear so fast as a pulmonary edema. And go to the next, please. And so we have seen Professor showed us the B-line pattern of the interstitial syndrome.
Maybe we should just go on. I think you still have one more slide or two more slides to show, and I think that's also very important because I also want to come a little bit to this topic of how difficult it is to work as a medical professional within a setting where you are, of course, at risk yourself with all this protective gear. What are some of your experiences here?
Yeah, this is a tracheostomy, and we use the combined ultrasound and bronchoscopy guided tracheostomy. In this situation, it's good because there are not evidences that the ultrasound is better than the bronchoscopy when used together or not. But in this case, you must be sure to do a good puncture at the first attempt. So when you use a combined ultrasound and bronchoscopy, you can be more sure than in other circumstances in which you are safe, you are in safe condition. But in this situation, you see, when we perform a tracheostomy, we stay a long time, and it's very. We are very tired when the procedure finished because we sweat a lot. It's awful. It's awful, and when our colleague will try, it will be very tired for all, I think.
Yeah, we definitely have a lot of understanding for these situations. Like many of you have probably worked in patients, seeing infected patients, but there you can, of course, go back and see normal patients again, but very frequently you have to work in an environment we only see these patients. So that's a really, really big burden, I guess, also on all of us with probably, night shifts after night shifts, taking care of patients, a really, real big burden on all of us, absolutely. A question maybe to you, just a very quick answer, because I've been asked that, and I also see it's been one of the questions that have been asked quite frequently. Do we see myocarditis? Maybe Jonathan and maybe both Lara and Baldo, what is it a simple answer, yes, no? Do you see it? Does it occur?
Yeah, I think we start to see because we start to look at that. If we don't look at that, maybe we can have a delay in the diagnosis. But I think now that we have the first data from China saying that around 15% of patients can have the disease, then we started to look at that. And I think we can find even more than 15%.
Yeah, we see an elevation of troponins in many patients and CKs. That's what I've at least been reported. Lara, Baldo?
Yes, we see that troponin is high in these patients, and so we start to look at the heart.
Okay. So, and you can see the enlargement of mediastinum in the X-ray. Maybe if you see more deeply, you will see subtle myocarditis in all patients, like in all viral infection. But in this case, I don't understand why in most patients with the important myocarditis, the right ventricle with low pulmonary pressure is involved. I have seen two cases, and I don't understand why.
I guess there's a lot of things we need to figure out. Let me just give you a short update. I just see that we have probably close to 12,000 unique viewers. So this is a huge crowd who has been interested here. Of course, we cannot cover all the topics. I'll maybe just shoot a few questions very quickly so that some of them are answered, because one question that keeps on arising is, are there late sequels of the disease? Michael was asking, what about permanent lung damage, fibrosis? There is reports in the literature. Maybe do you have, of course, we probably don't have as much experience, but have you heard about that? And
we know this from SARS. In SARS, we saw a number of cases with fibrosis. In this new disease, COVID, is not that well established. It is to expect it to be seen, but we don't have enough data here. Okay. So I can't really report from our data.
Okay. Jonathan, have you seen this?
Well, I agree. I mean, what we have looked in is a report on SARS-1, and actually SARS-1 had higher mortality. But if we transpose the results to SARS-CoV, then the future can be really scary, because in SARS report that up to 36% of patients that recover then develop fibrosis at 6 months. So that's also something that we could have to take care after the outbreak.
Mm-hmm. A question that is popping up, do you use high flow oxygen therapy for COVID patients?
Yeah, we use the high flow oxygen ventilation to improve oxygenation when it depends how many ventilators are needed to or occupied by other patients. But we don't understand if in this situation high flow oxygen therapy ventilation or non-invasive ventilation is the best one to improve oxygenation, because how I explained before, maybe when you put PEEP on the lung, you have a good increase of the PF, but you can delay intubation and doing another damage to the lung. So maybe high flow oxygen ventilation is better in this situation where there is a lot of inflammation on the lung. But
okay, no, so you also have to consider with the high flow nasal cannula, you have a high spread of the virus in the environment.
Yeah,
so you have to be careful to use it.
Yeah, because there is a danger to use any equipment or another. Where you use high flow oxygen ventilation, you have 40 or 50 liters or more for minutes that are going through the nose, and if you are near the patient, you can take all the spread of the air from the patient. That is not good for us. So it depends from the environment. In my opinion, it is good, but you must select the patients.
The right patients. I think we should slowly come to an end. I see there's many more questions. Like I mentioned, we don't have the time to answer all of them. Please, we have them now in our database, and we will try to answer them and put them on the platform doc-19. So please, of course, log in there, send some more questions, and look if you find your question there. And definitely think this is something that we want to push further and get more information on. I do want to thank very much, first of all the people who've been working on this. It was a tremendous effort on our side because we are now in a lockdown as well. It's very difficult for us to organize things. Our technical team, Giulio and Alex, and of course Robin, who's been here, and Stefan, they've done a tremendous job in organizing this through all difficulties, with difficulties in lines, and we usually do that in our studio setting, but here we're now almost in a little bit of a shack. Still, we try to make it as, of course, comfortable for you out there as well to see. I also want to thank the sponsors who've kicked in and helped us to support this, because obviously there's a financial need to produce something like that. And I can only also thank the speakers. Up front, very much our Italian guests. They're dear friends, long friends of the community. And I know again that this is something that is time for them that they could maybe spend with their families and relax, something they would need as well. But they're still so dedicated in treating patients, and you can again be assured that we have all the sympathy for you and all the support that we can give you. I'm sure we got so much from you during this webinar that will help us and maybe even save lives. And of course, I also want to thank Helmut. I do think that this information about lung ultrasound and CT is just of enormous importance, because it's a very simple tool, especially lung ultrasound, that will help us to make the diagnosis early. So again, thank you very much. Stick with us. Let's see if we can maybe put up a webinar again.
And thanks to Jonathan as well.
Yes, of course. Yes, I just meant the entire Italian crowd, of course. Yes, I do want to show a few things at the end, because I think it's just important that you also see this too. I promised that, and that is the database that Jonathan put up. You've got the web address on the bottom. We can, of course, send it to you if you are interested, if you are working in an intensive care setting where you are seeing patients, where you are maybe also in a position to get your head of the department to contact Jonathan and to maybe take part in this initiative. It will be enormously important because that's where all the data should go together so that we find out what is really, really the problem in these patients, obviously to help others. So again. Thanks Baldo, thanks Lara, thanks Jonathan, thanks Helmut, and thanks to the team again, and hope to see you maybe soon on a webinar where we can give you information that I hope is important for you. Thank you again.